Good morning, everyone. Thank you again so much for joining us for the Elizabethtown College COVID-19 lecture series. I'm Jesse Waters, director of the Bowers Writers House here at Elizabethtown College. Again, so glad that you could be with us for these experiences. This is the last of this particular series of lectures that we are offering, though we're very excited about some of the things that we're planning that will be coming up for the late spring and early summer. So please stay tuned to our college website, etown.edu, for more information on other offerings that the college will be delivering to the community. Today, we have a very interesting experience. You know, so many of us every day as we're securing in our homes and wondering just exactly what this experience means for us as individuals and social creatures, we sort of wonder what's going out there in the world and what a pandemic like this means for communities such as ours. And our presenter today is going to talk about just that. Let me remind you that throughout the presentation, you're welcome to use the Q&A feature to send in questions for our question and answer period at the end, and I encourage you to do so. Our presenter today is Dr. Deborah Waltermeyer Burton, who is an assistant professor of occupational therapy here at the college, who has a primary clinical background in adult psychiatry, but has also worked as a consultant in an acute care medical center with a physical rehabilitation program. Really looking forward to this program, and so without further ado, I'm going to turn it over to Dr. Waltermeyer Burton.
Thanks, Jesse. Thank you for the opportunity to talk about public health. I do want to, before we get started, I do want to say that how much I appreciate our alumni who are working in healthcare, for nurses, doctors, respiratory therapists. We know that this is a tough time for many of them, and so we appreciate the work that you are doing. And also for our grocery store workers and the farmers and the truck drivers, these are people that are really helping to keep our society going. So we really appreciate them for sure. So what I want to talk about today is a little bit about the history of pandemics, epidemics. What does this mean from a public health standpoint? So I went back to the Spanish influenza of 1918, which was probably the last major global pandemic like this. And we're going to compare what's happening now to then. But if you look on this timeline, you can see that we have had other incidences of outbreaks, smallpox, polio, different outbreaks of influenza. Certainly the AIDS epidemic continues because we don't have vaccines for that. Then we move into the 2000s, and we had SARS that started over in Asia in 2003. And more influenza, MERS, which was mostly in the Middle East, and Ebola. Most of those were able to be stopped regionally. And then that brings us to today with this bright red circle of the COVID-19 and the epidemic or pandemic that we're dealing with now. So then the question is, well, how is this different? How is this different than the flu? We've seen the influenza. Aren't they the same thing? And they really aren't. So an epidemic is really when you see a higher than usual outbreak of a disease, and it's usually in a country or a region. So we have had regional outbreaks of influenza, but they're usually contained. They're not worldwide, unlike the Spanish flu, but the ones since then have not been worldwide. SARS in 2003 was mostly contained in very specific regions. Ebola was really contained in specific regions. It didn't really travel very much, which is different from a pandemic. Pandemics is what we are dealing with now, and that's a widespread disease. It is impacting people around the world, and because this is a new virus, we have to assume that everybody has equal opportunity to be exposed. And I saw somebody call a pandemic an epidemic with a passport. So that's why I put the passport up there, because pandemics are diseases that travel. And we have seen that definitely in this instance, that this disease has traveled. And the most recent pandemics that we can think about, I mentioned the Spanish flu from 1918, that definitely traveled. There was an outbreak of influenza A in 1968. It didn't travel as much as the flu of 1918, but we are now faced with a pandemic that is traveling, and it is spreading worldwide. And so we need to look at the history of other pandemics to see what we can learn from them. So this is a picture from an emergency hospital in Kansas. And then this is also a photograph that came out of some National Archives and Records showing parades. So we know that the influenza of 1918 traveled with the soldiers as they were coming home from the war, which is one of the reasons it traveled so widespread. And there were various cities in the United States that had parades to honor their soldiers, which is a really great thing. But it put a lot of people close together. And even though there were concerns about the spread of the influenza, the parades were held anyway. And several cities, including Philadelphia, had an increase of outbreaks of influenza after those parades. So it would suggest that maybe those large group gatherings may have contributed to this. And there have actually been a couple different epidemiologists who have studied the patterns of the influenza from 1918 and actually have published papers showing that places and cities that did these kinds of parades did have outbreaks, and that the places that didn't do the parades and the places that were a little bit more conservative in their social distancing actually had less outbreaks. So there has been some evidence to suggest that perhaps the social distancing has worked. So again, what can we learn from this? The influenza of 1918 was an extremely severe flu. It did have a high death rate, especially among young adults. The hypothesis is that it did not impact older adults as much because they may have been exposed to a different strain of the influenza, maybe during the 1800s. We don't know that for sure, and I didn't go that far back in my research. But we also know that the influenza of 1918 and 19 had 3 waves of outbreak. So it would settle down and then it would surge again. As I mentioned, it definitely followed the paths of the soldiers. They were in cramped conditions and close quarters, not able to be taking care of hygiene and all those things that can help keep infections away. And so they got infected and they were on ships and they came home and they brought it with them. During that influenza pandemic, there were some steps taken that definitely helped curb or slow the spread. I mentioned the social distancing, but during that time, the government and public leaders did use quarantines and isolation. So they identified people that had suspected cases or definite cases. They isolated them and they were very carefully monitoring communities. They closed schools, they closed public places. They shortened Sunday worship gatherings to, I think, 5 minutes because they really wanted to limit the exposure that people had with each other to limit the spread. And so there was evidence that when that happened, it actually worked. When the SARS and the MERS outbreaks happened in the 2000s, again, they were not worldwide pandemics. They were more local or regional outbreaks. And the countries that were impacted by that isolated people who were infected. They were able to get them into some negative pressure rooms or healthcare units to limit the spread of the disease. And they also identified and isolated people who had suspected infection, again, in order to curb the spread. And so we saw with these that although they were deadly in those regions, they did not spread worldwide because there were some steps taken to help slow the spread. So what does this mean for us now? As I mentioned, this is a brand new virus. We have no natural immunity to it. If you were able to listen last week, my colleagues, Dr. Wohl and Dr. Lancaster, talked about immunity, and they talked about viruses and how they impact the body. So we don't have any natural immunity to this. Again, there is evidence that shows isolation and social distancing are effective at slowing the spread. They're not going to stop the spread, but they can slow the spread. And that's important because we want to be able to take care of the people who do get sick. And so we need to make sure we don't overwhelm our healthcare systems. And it also gives us time to develop vaccines. Other things that have worked have been to identify cases and track them or trace them to identify people who are at risk and to isolate them. And that is something that we have seen other countries do more effectively so far, even with this outbreak of COVID-19. Taiwan, Singapore, and I think New Zealand have all been pretty good about doing some contact tracing. So they identify people who have been exposed, and they isolate them, and then they can also trace to see who else they've been exposed to, again, to try to limit the spread. So this brings us to this situation, and forgive me if you've heard the topic or the term herd immunity, but I do want to explain it because I think it helps understand where we are right now. So if you look at this diagram, this is where we are right now. We are in this period of having no immunity. So you see, here's this population of people, and the people in the red are the ones that are infected. We don't have a vaccine, we don't have any natural immunity, so the infection is spreading very quickly, and it is spreading through very minuscule, invisible droplets in the air, and it spreads because people are sick and they don't even know it, and they're out and about. So it spreads very quickly. We end up over here with several people dying, and the people who have been infected develop immunity because they've been exposed to it. That is one way to look at herd immunity. It is not the ideal way because you have a lot of people dying. So where we are right now is this mode of social distancing, and I realize it's very challenging for people, but if you look at this, again, we don't have any vaccines, we don't have any natural immunity, but the boxes around these people represent social distancing. So if you look, the social distancing is almost putting an invisible protection around us. And so you still have people who are infected, but the social distancing means that the infection's going to spread, but not as many people are going to get it. The end result is you still have people dying, which is unfortunate. You still have healthy people who do not have any immunity, and you have some people who have acquired immunity because of exposure and recovery. This is where we are right now. Ideally, what we would like to do is be down here to develop a vaccine, and we know that a vaccine is at least 12 to 18 months away. When we have vaccines, we can immunize people ahead of time. The infection has a much harder time spreading, and then you have much less deaths. So we are in this middle phase, and again, this middle phase is to buy us time. It's to help the scientists develop the vaccine, to develop good treatments. It's to help the healthcare systems not be overwhelmed, and it's to help limit the number of people who are going to get sick and die. And I hear people say, well, the death rate's not that high. Well, it may not be, but those numbers represent real lives. So, the numbers may not be high, but statistics do represent people's lives. So let's talk about the impact of this virus. So I'm going to talk about the impact of the virus on people who actually get sick and what that means. We're going to talk about the impact of the virus on healthcare systems and the impact of this on society as a whole, which is where many of us are feeling this right now. So this is our current situation. These are some statistics that I was able to pull up yesterday. Worldwide, we have over 3 million cases. We have over 216,000 deaths. That is a case fatality rate of 7%. So that means the number of people who have died out of the confirmed cases is 7%. Now that number may shift because confirmed cases are people who have tested positive or have probable cause because of their symptoms to have had COVID-19. In the United States, we have over 1 million cases, and as of yesterday, we had hit over 58,000 deaths. Our case fatality rate in the United States is 5.4%. That number of deaths is very quickly approaching the average number of deaths from the influenza. So we will likely surpass the amount of deaths from the influenza based on this virus. In the United States, or in Pennsylvania, we have over 43,000 confirmed cases with over 1,700 deaths and a case fatality rate of 4%. So again, the case fatality rate can change as you test more people, but and you may have more confirmed cases who recover. But this is the data that we have right now, and so we need to use that data. But so just kind of a background of where we are right now. So how is this impacting the person? We know that this is a respiratory illness. People who test positive for COVID-19 have a range of symptoms. Many people have mild symptoms and may not even know that they have COVID-19, and they may not be very bothered by it. Others are going to have more severe symptoms. The milder symptoms tend to include muscle aches, headache, sore throat, and a new loss of taste or smell. And that new loss of taste or smell was actually just added by the CDC this week as a symptom. Based on some information and data from the CDC, amongst patients who actually went to the hospital, more than 80% of them had cough, fever and chills, and shortness of breath. Overall, the hospitalization rate based on our population, not based on people who test positive for COVID, but just based on our population, about 4.6 out of every 100,000 people are being hospitalized for COVID-19. And we know that that rate definitely increases with age. Very, very few children and infants are being hospitalized. There are a few, but not very many. There are people in their 20s, 30s, and 40s who are being hospitalized with this. So, young people who think they are not at risk, they are at risk. But the hospitalization rate definitely increases with age. And the other thing to remember is that if somebody needs to go to the hospital, because this is such a high infectious disease, that patients are going to be isolated from their families. So if someone's in the hospital, this is not like, going to visit somebody who just had their appendix out. They will not have any visitors. There may be exceptions if they're close to death, but for the most part, people are in the hospital by themselves. And so that's very stressful for the patient too. They're very sick and they have no one there to kind of comfort them other than the nurses and the doctors and the medical team. And so it really is a different form of hospitalization for people. The exception also would be children. The few children that are being hospitalized can usually have a parent with them, but adults are going to be isolated and going to be on their own. I also looked at some risk factors. Why are people being in the hospital? What's going on? So from the CDC's weekly report, as they're looking at their data, during the first 3 weeks of March, 90% of the people who had to go to the hospital had underlying conditions of obesity, hypertension, chronic lung disease, diabetes, and cardiovascular disease. So those pre-existing conditions and health-related conditions may make people more susceptible to having a worse outcome. They also found slightly increased hospitalization rates for males, as well as for African Americans. And one of the hypotheses about, or at least for the African Americans, is that we know that they, as a population, sometimes have less access to healthcare, and there are disparities in healthcare anyway for them, and they may have more of these underlying health problems because they don't always get the same access to healthcare. Some other identified risk factors, again, based on data, we certainly know that having family members and friends who live in long-term care facilities, group homes, they are at really high risk for catching this because of crowded living conditions. And anybody else who lives in crowded or close living conditions is also at risk. So when you think about large apartment complexes where people are in close contact with each other and interacting with each other, even in the lobbies, there's always going to be a high risk for more transmission of disease because they are close to each other. Counties in the US that have high rates of poverty also have higher rates of hospitalization. And that may be related to that people who live in poverty also may be living in more crowded conditions. They also may have less access to healthcare services and may have some of these underlying health conditions as well. So this kind of data gives us some ideas of who might be at higher risk so that we can look at those populations and hopefully maybe try to prevent some of this. And again, all of this data is new. So let's talk then about the impact on healthcare systems, because one of the reasons that the policies were in place to do some social distancing were really to help eliminate or minimize the impact on healthcare systems, because healthcare systems have limited resources as well. So the original estimates for this pandemic were that 20 to 30% of patients who tested positive might need to be hospitalized. These estimates came in from data as other countries were establishing this pandemic. And so modeling based on previous pandemics of the influenza, modeling on data coming from other places, the estimates were 20 to 30%, including many of those needing ICU. So from a public health planning standpoint, your modeling does want to look at a range of possibilities, and you certainly want to plan for the worst. You hope for the best, but you plan for the worst. So we had these estimates, and so based on those estimates, we needed to look at, well, what's available in the United States? So in the United States, we have approximately 54,000 ICU beds that are only for adults. So that doesn't include pediatric or neonatal ICUs. That figure does not include VA hospitals, military hospitals, or specialty ICUs such as cardiac ICUs or ICUs for treating people with burns. So 54,000 ICU beds. In Pennsylvania, we have just a little over 3,300 ICU beds, and some of those might include pediatrics because I couldn't quite get those numbers, couldn't dig down to get those numbers. But just looking at the numbers makes you realize that we have a great medical system in the United States, but we do not have an unlimited amount of supplies. So the healthcare system's response was to then, this is the third step, was to then postpone or cancel non-urgent visits and procedures and testing and imaging. And that was done for two reasons. One, they wanted to limit the exposure of other people to COVID-19 by not having them in the hospital. But they also wanted to preserve their protective equipment and their supplies to be used in the ICUs in the places where it was going to be needed more often. So this is the kind of that fourth point there, is that they really needed to manage and preserve the equipment and supplies that they had because they didn't want to run out. So we've seen all of this happen, and they also needed to then, this is the last point here, was training of staff members to do different roles. So training nurses and respiratory therapists and people to go into ICUs who might normally be doing that so that they would be prepared to use their staff where they needed them, or taking people who were used to doing outpatient services and retraining them to do inpatient floor-based nursing if they needed. Hospitals also needed to acquire extra supplies, which they did. I know of one children's hospital that actually converted half of their pediatric ICU beds to adult care, and that included physically building a wall and making sure that the new adult beds would be negative pressure so that they could protect the health of the pediatric patients and limit the spread. So hospitals and healthcare systems had to go through a lot to prepare for this. And again, this was based on the estimates of 20 to 30%. What we have seen so far is a hospitalization rate of around just under 10% related to COVID-19. So this is actually a good thing. So I hear people say, well, it hasn't been that bad. I'm like, well, we should be glad it hasn't been as bad as we were predicting. So there have been areas of the country that have had surges and have had challenges in meeting the needs because of the high rates that they've had in those areas. And so those hospitals have really struggled, but overall our rates have been lower, and I think that's a good thing, and we should be grateful that we haven't had as many problems countrywide. Again, there have been areas such as New York and New Jersey and Philadelphia that have been hit hard. Also, what we expect to see is that healthcare systems will have some long-term economic problems because of decreased hospital capacity. So the postponing of procedures and postponing services and images means that many hospitals are not at full capacity. And so their budgets are based on having a certain percentage of beds filled on a regular basis. So hospitals are likely going to face some economic downturns and some economic challenges as they need to recover from this as well. And also many healthcare providers did a very rapid shift to providing telehealth services, just like we in education had to do a very rapid shift to online teaching. Healthcare providers had to do a very rapid shift to telehealth. They needed to make sure that their patients had access to technology. They needed to make sure that their providers had access to the correct technology, including privacy. And it wasn't just a simple act of, oh, we're going to do telehealth now. They needed to look at reimbursement for telehealth and there have been some emergency legislation acts that have been passed so that Medicare and Medicaid are paying for telehealth. Insurance companies that are compliant with the Affordable Care Act's market-based exchange are going to be reimbursing for telehealth. At least that's supposed to happen. And even for providers, there was a scramble to make sure that official licensing acts and regulations were in place to make sure that everything happened. So there were a lot of pieces that had to come together, not only the healthcare systems planning for the logistics of patient care, but there were a lot of policy and reimbursement issues to be considered. The other major concern that I see for healthcare systems is the impact on their workforce. We know as of yesterday, Secretary Levine from the State Department of Health reported over 2,500 healthcare workers in Pennsylvania have tested positive for COVID-19. That means that you have healthcare employees who cannot come to work when they are sick. They are not going to be coming to work until they are recovered and no longer infectious. So that puts a strain on your healthcare system because you have people who are too sick to work. Psychologically, healthcare workers during pandemics are also at high risk for developing depression, anxiety, stress, and post-traumatic stress disorder, or PTSD. This is very well documented when healthcare workers have gone into emergency situations such as disasters like tornadoes, floods, hurricanes, earthquakes, but it's also been documented related to pandemics. An initial study that came out of Singapore with this current COVID-19 outbreak showed that healthcare workers in Singapore were experiencing depression, anxiety, stress, and PTSD. And then another study that came out, and that's the one that's referenced here on this slide, was actually asking healthcare workers very early in the beginning of this pandemic what their concerns were. And so healthcare workers had a lot of anxiety about whether they were going to have sufficient personal protective equipment, concerns about their own safety. They were concerned about getting sick and maybe taking this home and spreading it to their family members. People were anxious and concerned about having available childcare when they were working longer hours, especially with schools being closed and shut down. And so there was a lot of stress for them to think about managing their own family lives. There was also some anxiety about the need to train to do new roles. So for nurses and healthcare workers who were going to be training to go into the ICU who had never done that before, there was a little bit of anxiety about that. And so these are some documented concerns. And there's also literature that would show that anytime healthcare workers work in areas where they see high amounts of death and very traumatic experiences, that they are at risk for some emotional exhaustion, and they are at risk for some psychological distress amongst the workforce. So I think healthcare systems also are going to have to be paying attention to their healthcare workers to make sure that they are meeting their needs as well. And then I think this is probably what a lot of people want to talk about, is how does this impact those of us who are not on the front lines of healthcare, we're not sick, but we're living here in this society where we have this partial shutdown, we're sheltering in place, we're not going out. And so we have this idea of this social distancing and this partial shutdown, and I really liked the image of the iceberg, because what we see is the stuff on top about the COVID-19. What we don't see are some of the long-term impacts that this is having on people. So economically, we see high rates of unemployment, and from a health perspective, which is my take on this, when people are unemployed, they may have trouble paying for housing and food, which has its own health problems. We have plenty of people in this country who live paycheck to paycheck. There are people all over the world who really don't have a lot of economic resources. And so this issue of not having businesses open really is going to impact their health, just in terms of being able to pay for their housing and their food. If people have lost their health insurance because they've lost their jobs, that is a significant health problem. Yes, they may be eligible to apply for Medicaid, and they may be eligible to purchase health insurance through the ACA, the Affordable Care Act exchange. But going through that enrollment process is stressful, and there is a time lag. So there's a possibility of having gaps in time that people are uninsured. So that has a lot of risks from a health perspective. Certainly, we need to think about vulnerable populations during this time, which again is a health concern. There definitely are risks for children to be abused because they are in a home that may not be the most comfortable for them. They may be in homes where they do get abused, and they're not going to school where they can get a break. They're not going to school where maybe somebody can notice that they're in trouble. So that is a concern. And certainly people who are at risk for domestic violence, they're going to be sheltering in place, perhaps with the person that is the aggressor. And so they may be at higher risk for domestic violence. We know that is a concern. And again, sheltering in place makes it harder for them to reach out for help because they're always with that person. I know that teachers have been trying to connect with their students when they've been doing online classes. But again, from a health perspective, there are some long-term concerns by having this social distancing and shutdown. People's daily activities have changed. So the disruption in routines can be very difficult for people cognitively. When we have a disruption in routines, we use way more cognitive energy to figure out what we're doing. You know, routines become so automatic that we can use our mental energy to do other things. Well, now we're using our mental energy just to figure out how to manage this new normal. So this is going to impact how people do their leisure. It's impacting their eating. We joke about the quarantine 15, but there certainly is a concern that people may be eating more. They may not be getting as much exercise, and there may be some long-term physical health problems related to this. People are dealing with the stress of trying to manage their children's education and working from home. And again, that's stressful and that can lead to more conflict. So there are some potential health problems related to that as well. On the flip side, some people have really embraced this, and we see people doing jigsaw puzzles, and people are getting out and doing, and maybe they are exercising more. So I think we have yet to figure out the complete picture and how this is going to impact that. But we do know that it has disrupted people's daily activities. Psychologically, for the general public, dealing with prolonged social distancing and isolation is going to lead to depression and anxiety and post-traumatic stress disorder. And again, and that might be related to the unemployment as well. People who lose their jobs also may suffer from more depression and anxiety. People who already have those conditions, this is going to be made worse for them. And there was actually a study from Toronto, because there was an outbreak of SARS in Toronto in 2003 and 2004, and 28% of the people in that study suffered from PTSD as a result of the social distancing and dealing with the fear and the anxiety of the pandemic, or what they thought was going to be a pandemic, which was not. It was an epidemic. But again, the mental health of people in general is significantly concerning during this time because of all of the imposition of the social distancing and the isolation. I mentioned that healthcare systems had delayed a lot of procedures, and so we need to be thinking about, well, what does that mean for the people who have not been able to get in for their imaging or their testing? Surgeries have been postponed. What does that mean? Are those conditions going to worsen before they need to be treated? So I think that there are some chronic conditions and things that have been postponed that may worsen before they are able to be treated. Just yesterday, the Secretary of Health in Pennsylvania announced that ambulatory facilities can start doing procedures under certain guidelines. So I think we will gradually see a catch-up phase for this. But again, there are some risks for having certain procedures delayed. Dental care, dental appointments have been postponed, and dental problems and lack of good dental care can lead to other health problems as well. So we definitely have some long-term health problems to think about. And then the last one on this slide is substance abuse. When people are depressed and lose their jobs, they may be using more substances. If they're bored and they don't have a productive leisure activity, they may use alcohol and drugs. So that may be on the increase. And certainly the opioid epidemic has been going on for years. That hasn't stopped. You know, that's kind of not on everybody's radar, but the opioid epidemic is still happening in the midst of this other pandemic. So we have a lot of health conditions and things to be thinking about and to be addressing beyond just COVID-19. That's the main thing on our radar right now. But there are a lot of other things that we need to be thinking about. So we have this notion of social distancing. It is going to start to be loosened up in Pennsylvania, and other states are taking different approaches to this. So why is this so hard to enforce or sustain? And this is really important from the notion of public health and public policy. So for people to understand the risk or to perceive what risk really means is very challenging during these kind of quarantines or social distancing episodes. In this particular situation, this is a very invisible illness. So unlike a disaster where you can really see that a hurricane is forming and you can see the radar, it's hard to see that. If people don't understand how this is being transmitted, even though the public health officials have tried to explain to them, this is still an invisible disease, and people really don't understand it. People who think that they themselves are not at risk because they're in a low risk category, so their perception of risk is very low because they don't think they are much at risk. But are they able to think about the risk that they are imposing on others? And some are going to be better than that at others. And do they understand really the issues? This is a brand new experience. It's been documented that in terms of natural disasters like hurricanes and tornadoes, that people understand the issues if they've experienced it before, but we've never experienced this. And again, the last major outbreak in the United States was over 100 years ago. The few people who may still be alive would have been so young then that this is not in anybody's personal memory. So people tend to respond with a lot of denial. Oh, this really isn't as bad. Or they don't believe it's going to happen to them. Again, they rely on their personal experiences, and we don't have any personal experiences with this. They also tend to rely more on the advice of family members, coworkers, friends, and celebrities. So again, their perception of how risky this is going to be impacted by their social environment and the people that they associate with. Quarantines are also hard to enforce because of the messaging and the communication. So whoever is giving the orders, whoever is making the statements needs to be someone who is trustworthy. If people do not trust the person who's giving the orders, they're not going to want to follow the quarantine orders. And this is not just in this pandemic. This is documented with the Ebola outbreak. It's been documented in other countries with the SARS outbreak, that if there's a sense of distrust with the government or the officials who are making the orders, it's really hard to get people to follow those orders. People also hear conflicting information from various sources. That has happened this time only because the information changes as we get more data, but they get conflicting information from sources. The internet really spreads a lot of information, good or bad, and so people hear different things. And so they don't understand how serious this is, and they don't want to follow the quarantine guidelines. They also hear inaccurate or exaggerated information. So again, the modeling was looking at worst case scenario, and then when they see that it's not as bad as predicted, then again, they're like, well, why did we have to do this quarantine? It wasn't that bad. So it's really hard, I think, for some people to understand the science behind this and the information in terms of how it's presented. Financial issues and access to support services also make it hard for people to stick to the quarantine. In fact, when they had the SARS outbreak in Toronto in 2003, the loss of income was one of the main reasons that people did not comply with the quarantine, because they had to work. So people need to work to feed their families. If they're older or they're isolated and they don't have access to support and services, they're going to go out and take risks because they need to take care of themselves. And then the other thing, which may be unique to the United States, is this philosophy of people being responsible for themselves and wanting to make their own decisions and really not wanting the government to tell them what to do. I see this on social media. There's definitely a backlash about sustaining our individual rights. So the question is, doing this social distancing, have we flattened the curve. Well, based on the latest deaths, this is deaths in the United States. Let me see if I can draw a little line here. It's possible that we may be seeing a slight decrease. I personally think it's a little too early to know if that decrease is going to be sustained. It looks like we may be kind of plateauing. We certainly have had a very slight decrease, but I think from a public health perspective, it needs to be monitored for a couple more days or another week or so to really see if we can sustain that, because we don't want to see those rates go back up. So, and I'm almost finished here, but some of the challenges that I see, we need to slow and minimize the outbreak, which I think we are seeing it slowing down. We need to do more testing and contact tracing so that we can really get a handle on who is sick, who's been exposed, and how do we minimize that risk. And part of that is to prevent a second wave or a surge. We don't want to see those numbers go back up. We certainly need to meet the immediate needs for supplies and equipment and keep that going and replenish supplies. And misinformation, I hinted at that on the last slide, but misinformation is really significant in this outbreak compared to any other outbreak. Even with the SARS from 2003, our technology and our use of the internet and social media has really exploded. And so it is really easy for misinformation to go viral, just like the disease is going viral. Anybody with a smartphone can record something and put it out there on the web. And so that's a real challenge for public health officials to try to manage those rumors and the inaccuracies. The opportunities, as I see them, would be, again, going along with that misinformation, to develop and continue to communicate clearly and effectively with people. We need to develop effective treatments and vaccines, and always need to learn from this experience and plan for the future. So how would we coordinate communication in the future? How do we train healthcare workers, public health workers, community workers for future pandemics? We need to replenish stockpiles. And personally, I think we need to invest in more public health infrastructure and services so that as a society, we're able to deal with this when and if the next pandemic occurs. And then on a personal level, we need to continually figure out ways to adapt and problem solve within our daily lives. So we need to engage in self-care. We need to make sure that we are dealing with our own emotions and taking care of our physical health. And we also need to be taking care of others. And I do see people reaching out and supporting others, and that's a good thing. So we need to be taking care of each other. And then lastly, I would definitely be remiss if I did not mention this in terms of mental health resources. We know that mental health issues are very serious and have high risks during this time. And as someone who has worked in adult psychiatry, I certainly want to just reiterate the importance of reaching out for help. There are certainly plenty of people around you. These are phone numbers and text numbers that you can use. The crisis text line in the middle is for Pennsylvania residents, but I am sure that if you don't live in Pennsylvania and you text that number, they are going to help you find the resources that you need. And I think that's everything. So I'm going to stop sharing, and thank you for listening to me talk for over half an hour.
What a great presentation, Dr. Waltemara Burton. Thank you so much. And we've got a handful of great questions that have come in here. The first of which, if we begin to open up, do the U.S. public health officials feel we have enough respirators and medical supplies to handle a potential surge?
I don't know the exact numbers on that. If we do not have a surge higher than we have now, we've been able to manage the healthcare systems have been managing the current rate. So if that rate does not increase, it would make sense to me that we would have enough, but I don't have the exact numbers on how they're replenishing supplies.
Okay. Here's another one. I'm hearing 12 to 18 months for a vaccine, but CNN is reporting a few companies and researchers at Oxford's Jenner Institute think that they might have a vaccine available by fall, quote unquote, for emergency use. What does that mean? Is that timeline overly optimistic? And once a vaccine is tested, what's a realistic time frame for mass availability?
I'm not a vaccine expert, and if that's coming from Oxford in England, I assume. So anything that is tested has to be approved by the FDA. Last week, Dr. Lancaster talked about that process. So I think that's overly optimistic, at least based on the process that happens in the United States, because as Dr. Lancaster said last week, and I know this as well, that we want to make sure that the vaccine is going to be effective in terms of, does it do what it needs to do, but it needs to be safe. The last thing we want to do is rush a vaccine to market and then have people have all kinds of side effects and problems. So I think that's overly optimistic. It'd be great if it happens. Based on the past and based on what we know in terms of developing vaccines, I think we're looking at 12 months or more. But maybe we'll get lucky.
Kind of related to that, I have a question as a medical professional that has a strong background in psychiatry. What do you think or feel about the perspective of what we've heard from our president in terms of the ideas that are related to, well, when you have to throw that Hail Mary when you know you're in those last stages of life, just try anything. You know, here's, you know, that we should be willing to have that population of people have access to all sorts of cures which may or may not work. How do you feel about that principle?
How do I feel about it, or what do I think about it, are different things. I think that there certainly have been medications available in clinical trials for what's called compassionate use. And I think that if the patient is willing to take that chance, I mean, we've seen that with cancer, we've seen it with cardiac issues, that there are exceptions to some of that for people, but the person needs to be willing. We can't, as a healthcare profession, say, we're going to give you this treatment because you're in the last stages and it may or may not work. I think you still need to respect people's rights. So if someone is willing to take that chance and to try something that hasn't been tested, if there is good reason in prior testing to think that this may work and the person's willing, I think there has to be a discussion about that. That's my opinion, but it's way more complicated than that. Does that answer your question?
Yes, absolutely. And here's just, I think, such an important question. As an OT student, well, this individual is an OT student, and they're asking, have you heard anything on how OT services have been impacted by this pandemic? Has it shifted to telehealth, or are some occupational therapists, quote unquote, on the front lines as well?
It runs the whole range. So there are therapists who are working in hospitals, nursing homes, home health care. The therapists who are working in hospitals are still treating the people that are in the hospitals. I mean, people still have heart attacks, people still have strokes, people still get broken bones. And so there are people that will be in the hospital who still need therapy services. And OTs certainly work in intensive care units. And so they will be, and we know that there are therapists working in intensive care units. Therapists who do home health with adults are still going in and seeing their home health patients and working with them on the skills that they are doing in their homes. Rehab facilities, I haven't heard numbers specifically. I would think that if we are slowing down some of the hip surgeries and knee surgeries, we may see a decrease in the number of patients. Some therapists are also doing telehealth. So we have a lot of therapists in this country that do early intervention with infants and toddlers who are working on developmental issues. And a lot of them are now doing telehealth and working with their families, and they are coaching the mom or the dad or the grandmother on how to do the therapy. So we've seen a shift. And unfortunately, we do have some therapists who have temporarily lost their jobs because they're not able to shift to telehealth for whatever reason based on their clients. So it really runs the gamut.
Okay. And in your opinion, what do you think are the factors which contribute to the fact that the US seems to have much more cases than so many other countries in the world, and be those cases of infection or death? What is it about us and our community or our culture that's creating such a larger ratio in terms of growing cases and then potential deaths?
Actually, actually our death rate is based on confirmed cases is actually lower because we have good medical care. So I think it's hard. You have to really know what you're comparing with numbers. In terms of numbers, you know, other countries have been hit harder and have higher mortality rates. We do have a larger population. So if you just look at basic numbers, we're going to have more deaths because we have more population. We are a very mobile society. We travel a lot. We don't always live and work. We don't always live and work in the same community. You know, we are used to commuting and traveling. We don't always live near our families. And so I think as a society, we're used to that. We have a lot of people in this country who need to work, and so they're not going to quit their jobs. I don't have any hard data on this, but I know as I look at social media and reports, I think that pushback against individual rights and the suppression of freedom is something that people really don't like, and we're not used to that in this country.
Yeah, very, very true. Well, I think we have time for maybe 2 more questions. So I have here, testing will be critical, of course, to return to some semblance of pre-COVID-19 normality. Do you think on-demand testing will ever be a possibility in Pennsylvania?
I think that is a question for the Department of Health, because they are the ones that are looking at the testing. They have various centers right now. It's going to depend on the availability of the testing supplies. The laboratories have to be able to process the lab tests, and they're still doing, and laboratories also have to test regular things as well. So it's going to be really dependent on the supplies and the capacity for the labs to do that. Ideally, that's what we need.
As maybe a follow-up, what's your opinion as to why we don't? Why don't we have the access to testing that we should have or could have?
I really have not explored that in depth, so I can't give a good answer. In general, planning for a pandemic is challenging because you're planning for the unknown. So certainly stockpiling gowns and gloves and protective equipment is pretty straightforward. But when you're planning for specific testing, that may require certain chemicals, it may require certain supplies. It's hard to plan for what you don't know. You expect, and so I think I would say for people listening to this to really have a little bit of grace towards the public health officials and the scientists. They are working really long hours. They're spending a lot of time on this. And the way the scientific model works is you have your initial models and estimates based on the data that you get. And so you give your recommendations. And then as more data comes in, that model may shift a little bit. That's just a normal part of the scientific process. You know, if you think about statistics and how data shifts things. So even the CDC is going to change some of its information because they get more information and more data. And so I think for people to realize that the reason that we see some changes is because we learn more. This is a brand new virus. We're learning as we go. And so we need to give the scientists the time to do that. And I think they're scrambling, and I think they're giving the best information they can. But it's going to change as more information comes in.
Okay. And the last question we have here, after we quote unquote open up, when a new surge in this virus happens, will the US public health complete targeted quarantines, or will we all go back to just everyone being sequestered? Which of those approaches do you think will occur?
I think it's going to be handled at the state level, not the federal level. And I think that the governors are going to be looking at the surges in their states and in their areas. I know for Pennsylvania, they have 6 regions, and they will be monitoring outbreaks in each of those regions. So the decision to open up or to do a partial closure, again, it needs to be based on what's happening in that region. I don't think that you can make a federal policy that's going to work everywhere, because we have different parts of the country. Some are more rural, some are more urban. There are different needs. I think it needs to be based at the state level. And
Okay.
I think it is very possible that if we see a surge, we may see a temporary shutdown again to kind of get that surge under control.
All right.
I
Okay.
hope it doesn't happen, but it might.
Fingers crossed. Absolutely.
Absolutely.
Well, Dr. Waldemar Burton, thank you so much for that presentation. Really fantastic. Some great data, some great expression. Really grateful that you could be a part of our experience here. And to all of you that have joined us once again, thank you so much for being part of this lecture series. It's been an honor and a privilege to be able to be the MC for this series. And let me just one last time express my heartfelt thanks to the folks here at the college who are in ITS and the Office of Marketing and Communications. Without them, these kind of things simply couldn't be possible. When we started this lecture series, I was having a very brief conversation with Brian Helm in our ITS department, and he had mentioned back then that the college had already completed 3,500 Zoom sessions. And this was really right towards the beginning of this pandemic. So these departments here at the college that have made this lecture series possible have just gone above and beyond. And thank you as well to Drs. Fletcher McClellan, Jeff Bach, David Kenley, Mr. Joel Januszewski, sorry, Doctors Jody Lancaster and Deb Wall for your time and energy, and you, Dr. Waldemar Burton, for offering your time and energy to this lecture series. As I like to say at all of the conclusions for these events, our mission here at the college is educate for service, but all of us here so definitely believe in service for education, which is why we wanted to offer this lecture series to our communities. And please stay tuned to our website as we are discussing other ways in which we can serve our community and offer more dynamic experiences during this time. In fact, if any of you have suggestions for things that the college can be doing for being more engaged with you, our community, please simply send an email to writershouse, one word, at etown.edu. And for any of these lectures that we've offered, all of which are on record, you can watch these again simply by going to the COVID-19 link at the college's main website. If any of you have questions for any of our experts, please also send that question to writershouse@etown.edu and we'll pass those along. Once again, thank you so much to all of you for joining us. We're grateful for your presence in the Elizabethtown College community, as well as in the Pennsylvania, national, and global communities as a whole. I'm Jesse Waters, the director of the Bowers Writers House at Elizabethtown College, signing off.